It's definitely a very sensitive and touchy subject for a lot of people. And I think it comes from a lot of ego. I think where the issue comes along, where the lines are muddied, where certain employers or certain clinicians try to hide or confuse the patient by not explicitly telling the patient what their role is. A lot of people actually don't realize if they're seeing a physician assistant, a nurse practitioner, or a physician. The biggest frustration for many physicians is the ability for physician assistants to be able to jump specialties, transitioning from one specialty that they're doing for 1 or 2 years, now going into a completely new specialty, whether they have experience or not, and then being able to work in that specialty. Whereas physicians are never really allowed to do that. Once you specialize in family medicine, you can not go back and do surgery or become a surgeon. Medicine,
Law, friendship. This is Dr. Long and Lawyer Nik. You're listening to the Medico-Legal Brief.
one doctor, one lawyer, and a whole lot of gray area. Welcome back, audience, to the Medical Legal Brief. Thanks for joining us again for another episode where we talk about medicine and law with Dr. Long and Lawyer Nik. Today's topic is on the differences between physicians and physician assistants, specifically on the educational pathway as well as the curriculum that they pursue through their education. And I think Lawyer Nik is the perfect person to sit virtually across from me with the right questions or probing questions because he is coming from a non-medical background and he's had a lot of exposures to all the different types of clinicians in the medical field.
Dr. Long, I'm going to get right to it really fast. Is there some sort of unknown underground war between physicians and physician assistants? Because people get spicy about this topic. Is there something I'm not seeing where people are up in arms between the difference?
It's definitely a very sensitive and touchy subject for a lot of people, and I think it comes from a lot of ego. At the end of the day, there are enough patients out there to be taken care of by physicians and physician assistants. Where the issue comes along, where the lines are muddied, where certain employers or certain clinicians try to hide or confuse the patient by not explicitly telling the patient what their role is. Out in the public, a lot of people actually don't realize if they're seeing a physician assistant, a nurse practitioner, or a physician. And our goal is not to turn it into a controversial issue. Our goal is to just make sure we educate medical students, physician assistant students, and nurse practitioner students so that they know what pathways are going to be the best for them and what their career may look like and what they feel is the right fit for them. That comes with exploring the educational pathways that each career choice pursues so that they can decide if they want to commit the amount of time that they need to commit to reach their end goal.
Okay, now with the internet masses, obviously anybody can comment on a video, anybody can make a video. Credentials can be lied about, especially when it comes to internet personalities. For our listeners, you can look both me and Dr. Long up and see our credentials right there online. But as far as the workplace, as far as the water cooler talk, as far as the administrative feedback that's given to both physicians and PAs in the office, is there still this hidden animosity and hidden ego, or is it very cordial when you're working your day to day?
It depends. Depending on your work environment, just like anywhere you work, no matter if you're in medicine or not, there's always going to be a dynamic of egos, a dynamic of education, of pay, of gender disparities. There's so many different things that a lot of people are constantly trying to compare themselves to. This is another label that people use to, whether that's discriminate or choose to argue and fight about. At the end of the day, our goal is to try to help patients. Physicians' goal, sole purpose is to be there and try to help our patients live a long and healthy life. And I know that that's the same goal for physician assistants and nurse practitioners as well. But at the end of the day, there are some people who are just not willing to work together as a team to make sure that the patients come out on the right side of the tunnel there.
Okay. And I think that education is very important, and being familiar with what's going on is very important, being informed, I should say. So my first question to you, I know that you want to get into some of the education and credentials between the two, but if I am just your average person that doesn't have a lot of experience with medicine and I am trying to seek out a doctor or even seek out a PA, what are the letters after the name that I'm looking for?
So there are only two labels that come with a true physician. Physician is someone that has gone through medical school and then residency afterwards. That would be considered a board certified physician. There are some physicians who do not complete a residency, then they're considered a non certified physician. But you're looking for the two letters of either an MD, which is your traditional medical doctor that most people think of, and then there's also the DO, which has been growing in the last couple of decades and are equivalent to MDs, and that is the doctor of osteopathy. And the reason that they are equivalent is because both pathways, MD and DOs, go through the same 4 years of rigor, basic sciences, studying pathophysiology, pharmacology, all the different basic sciences, and then pursue clinical rotations that are set up by their school system. And then from there, graduating and then going into a 3 to 7 year residency. And both MDs and DOs can then go into fellowship. PAs are not allowed to do that sort of pathway. They have a truncated pathway because their role is to support, or was the original role to support the physician so that they can help cover for patients' needs, whatever that may be, in less high risk situations. And they were meant to help fill that need.
So essentially, a PA is playing the role as a support function, or historically, it has been a support function, but now it's taking center stage in helping patients, stepping in for the physician themselves.
The term that used to be used was that physician assistants were physician extenders, meaning they were there to help follow through with a treatment plan, whether that was a surgeon that had seen a patient do surgery. Now they're going through the follow up to make sure the bandages and everything is healing appropriately. They were never meant to do the surgery themselves. Or if they were following a hematologist who had done a bone marrow biopsy and had already started a chemotherapy regimen for a cancer patient, then the physician assistant can follow through with that plan, making sure that they're getting the right dosing, appropriate dosing, managing their side effects, those sort of things. That way, the physician is there to still maintain and do the brunt of the work, diagnosing, coming up with the treatment plans for the really difficult patients so that the more simple patients can still see someone. Because sometimes if your physician is blocked up and busy, sometimes you're not able to get in. So the extender is hopefully there to be able to fill that need.
And I've definitely used a PA before in the past for several things. If I can't get in to see my primary care physician, I will definitely see their PA, at least here in Texas, knowing that they fall under the tutelage of the physician. There's that safety net there of knowing that my PCP is still engaging with my health. Now, what are the letters I should be looking for a PA? Is it just name and then PA, or are there other designators there that exist?
Correct. The title for a physician assistant would be a PA. Most PAs come out with a master's. Some PAs come out with a doctorate. That is not as common, but most are master's degrees. And so they come out as a PA, and that's what you're looking for is their name and PA. Again, physician would be an MD or a DO.
Okay, but there does exist a world where a PA can have a doctorate and be referred to as a doctor, which muddies the waters a little bit more.
Correct. That doctorate title is not solely for physicians. Obviously, we know that because there are dentists, there are physical therapists, there are psychologists out there who are considered doctors. And so therefore we label them, we call them as that doctor so-and-so in the dental office or the doctor so-and-so in the physical therapy department. Where things get confusing is when you are in a medical clinic and you're there to see a physician and you're asking for your doctor. But then if there is a physician assistant or a PA that also has a doctorate, and if the PA themselves are requesting to be labeled or called doctor, it can confuse the patient. And that's where this educational episode is really important for our viewers, that they understand that there are actually some states out there that do not allow non-physicians to be able to use the term doctor in a medical clinical setting. They can do whatever they want in their social media, in their own private clinic if they wanted to. But when it comes to a medical setting where physicians are at or other medical treatments are given out or in a hospital setting, PAs are not usually allowed to use the term doctor.
Okay, yeah, I could definitely see where that would muddy the water, but I also see the controversy there because if you put in the work and you put in the hours, and from the categorical perspective, you are considered a doctor within your education, you've earned that title. You've earned the ability to be called a doctor. But that confuses the masses to where if they don't understand what those letters after the names mean, they are uninformed, then you really don't know who you're seeing and what they have gotten their doctorate in. Just like if I was a PhD in psychology or sociology, I would be on this podcast and it would be Dr. Long and Dr. Nik. And given that it's a medical legal podcast, that might convince our audience to make the assumption that I'm a medical doctor when really I'm not. I just have a PhD and I'm using the title that was well earned, but under the context, it can confuse people.
That landscape is forever changing and evolving. We're still trying to figure out how we can navigate that area of titling for different clinicians to make sure that everyone is as happy. And honestly, at the end of the day, we all know that you can never make everyone happy. At this point in time, everyone is using the term provider to clump everyone under the umbrella of clinicians. And there are some people who don't like that term either. But again, at the end of the day, the most important thing is that our viewers, the patients out there, understand that whatever type of care that they're seeking, that they get the care that they want by the person that they want. If they're seeking a physician, they should get a physician. If they're seeking a PA, they should get a PA. There is no reason to doubt the care of your clinician as long as you appropriately did your research, which I always encourage all my patients to do.
And doing this podcast has definitely helped me and my wife. I've talked about before, we got new insurance this year and I had to go select a different PCP. Now, the beauty of the internet and the beauty of some of these health systems is that I can go into a health system and I can look at all the available doctors per my insurance, and then also look at the credentials and where they've come from and what they specialize in and so on and so forth. I could go through and then filter by MD or filter by DO, filter by male or female, because that preference also exists. And then it also takes it a step further of filtering by telemedicine as to, do I just want to see somebody who's virtual or do I not want to see somebody who's virtual? Do I want to actually go into the office? And I'm curious to see where it continues to go into the future as things continue to evolve with access with healthcare and with medicine in general. Now, I do have a question for you to reset everything. When we're looking at credentials, how do you get to those letters at the end of the name? You've already discussed from a MDDO perspective, but how does that compare against a PA education? What are the routes? How do they overlap? How do they differ?
There is definitely some overlap. When I was doing my research, I actually looked at some universities that have both MD programs along with PA programs at the same university. That way we can compare the curriculums a little bit more thoroughly for this episode so that we can see what the differences in training are, the differences in education. If we are looking at the broad picture, specifically at Rutgers, Rutgers is a very well-known medical school as well as a fairly well-known physician assistant school. If we're looking at the overall timeline and how much time you're dedicating just to medical school and physician and assistant school. To become an MD, you're spending 4 years. To become a PA, you're spending 3 years in PA school. At the end of it, one comes out with a doctorate, which is the MD. The other one comes out with a Master of Sciences in PA. The basic sciences are done within 1.5 to 2 years at Rutgers. So you're spending those first 1.5 to 2 years dedicating yourself to the neurology, the pharmacology, pathophysiology, everything, the backbone of what medicine is, so that you can understand the ins and outs, so that you can then apply it to clinical medicine. At Rutgers, the physician assistant school, they only spend 1 year dealing in the basic sciences. The courses probably overlap, but because they're spending half the time that the physicians are spending, it seems that the PA component or the PA curriculum is likely shortened or maybe not as in depth. And that just makes sense. If there's not enough time, you've got to trim the fat wherever that may be. The other things that I am seeing is that there are research requirements for physicians at Rutgers. They are required to do certain scholarly activities as well as certain research electives to fulfill their doctorate degree, whereas physician assistants have the opportunity to, but are not required to do so. Where it overlaps is that similarly to physicians and physician assistants, both depending on what type of specialties they want to go to, it may rely more heavily on research, more academic prowess, and more resume boosting opportunities. If you're wanting to go into orthopedics or dermatology, either as a physician assistant or physician, you're going to want to do more research. The opportunities are there. One is required, the other one is not. And then finally, the overall goal that is set up that you can see within the Rutgers mission statements for the medical school and the PA school is that for physicians, the goal is to prepare the medical students once they graduate that they can then go to residency and then become physicians who will be independently able to practice. Whereas for the PA school, their mission talks about preparing themselves for PA practice or entry-level PA practice. So not practicing independently, but practicing under another physician's license.
There's so much there to unwrap and unravel. I would be curious to know whether or not those classes have prospective PAs or prospective physicians together in them at the same time. That would be a telling dynamic. Are we trying to hold at least the basics? I understand that the course load is a little bit more truncated for PAs, but are they at least learning from the same teachers and the same people and doing the same studying and even peer-to-peer study groups and coursework and so on and so forth? Do you know if that exists at all?
Yes, absolutely. I have a lot of PA friends and a lot of physician friends as well. And there are definitely classes both PAs and medical students take together. Specifically, here, if I'm looking at the Rutgers curriculum, it looks like anatomy is one that they take together. So, dissection, learning about the body, the different muscles, the organs, all those things are similar. It looks like they do microbiology. They have a similar class. Pathology is also very similar, and pharmacology is also very similar. But then that is where it starts to depart from where the physician is. Because again, remember, PA school has 1 year where they're dedicated to the basic sciences, where 1 and 1.5 years are dedicated to clinical rotations. To physicians have 4 years to do all this. So physicians go into histology, physiology, biochemistry, genetics, immunology, and that does not look like that is part of the Rutgers PA curriculum, not in a strict sense. I'm sure that they touch in some of those avenues, but it's not a strict course that they are required to take to graduate. The other things that look like they cross both sides from physician and physician assistant is certain diagnostic methods and patient assessment skills. It looks like that for physician assistants, they go into that fairly early and they're learning how to do those sort of patient assessments and asking questions. Whereas physicians, it's spread out across the first 2 years sporadically, but then they really hone in on those patient skills when they're in their clinical rotations in their third and fourth years.
Well, Dr. Long, I'm going to speak out for maybe some of the physicians, maybe for some of the PAs, but it's very interesting that you could have those two individuals in the same classroom, doing the same coursework, learning the same thing, testing the same way, and then have your PA get a better grade than your physician.
That is where it's incorrect. So just because they're taking the classes together does not mean that they're taking the same tests, because they're not. Just because they're taking gross anatomy together does not mean that the PA is doing the full dissection, getting down to the bare bones, getting down to the very vasculature, because they're not going to have the same amount of time. A medical student is going to have 3 to 4 months to dissect a full body, whereas a PA may only have 1 month to be able to do that same course. So, yes, they're in the same class learning the same things, but the breadth or the depth at which they learn the topic is going to be more surface level and not as in depth. The onus is going to be on the PA, whether or not they're willing to learn on their own time.
Okay, because I was going to say there are some instances, at least in law, where you might say, yeah, I was in contracts with so and so attorney. I wouldn't trust them to do your contract because I scored better than them or what have you. And so, applying that same logic, I could see in a world in which the prospective PA is taking the same test as a prospective physician, there might be some bragging rights there of, oh, I scored better on that test and he thinks or she thinks that I'm not as good as them. But from what I'm hearing you say, the testing and the evaluation differs even if they're taking the same coursework.
Correct. Just an example that I can think of off the top of my head is for a medical student who has to take both embryology and gross anatomy. When you're taking these tests, yes, you're getting tested on the body part, but you're also testing how did the body part come to evolve to that point? How did it migrate as a fetus or as an embryo into the location where it's at in a newborn? Whereas a PA does not need to take an embryology class. So there's no way they can get tested on that sort of knowledge. They can only get tested on what is this muscle? What is this nerve that runs through the muscle? More surface level things that are needed for them to pursue the career that they want, which is to be physician extenders and not be independent decision makers.
Okay. Moving past the educational aspect of it, then you want to go into experience. And physicians have residency. And I don't think I recall hearing you say that there is residency for PAs. So it sounds like they're just getting thrown out in the workforce, or is there any sort of on the job training that PAs go through?
Yes, the difference is physicians, for you to be board certified and fully licensed as a physician, you pick a specialty and you specialize in it, which means you then have to do the residency. PAs are meant to be physician extenders and they are allowed to jump different specialties. They're not required to pursue or complete a residency or for a fellowship because you want them to be able to have a broad spectrum so that they can pivot and transition if they need to. And so that is some of the appeal for people who would rather not be stuck in the same field for the rest of their career. The physician assistant is allowed to go orthopedics one day and then maybe decide to go to family medicine the next and then go back to OB. And as long as they have the skill set or the interest to learn, then if the physician is willing to hire them, then they've got the job. But again, physicians, we have to complete that 3 to 5 years of residency. And then, depending on which specialty, an additional 1 to 2 years of fellowship.
Okay, so even coming out, the experience is just different and the expectations are different. Do PAs still have to swear to the Hippocratic Oath?
No, they have their own oath. They do not attend the same sort of white coat ceremony that we have. They do not graduate with the same honors because one is a doctorate, the other one is a master's. They may have the graduation in the same locations, but again, the process of it, the procedures of it are very different.
Okay. Now, when we get into practice, you have mentioned on this podcast and several other podcasts, states' laws differ as to whether or not a PA has the ability to practice on their own or they have to practice under a managing physician. What's your opinion of that? What have you found?
In tradition, the majority, if not all, physician assistants are required to practice under a physician license. So, whether that is a supervisory role or a collaborative role. However, we are seeing nowadays that there are more states looking to allow independent practice for PAs. I believe there may be 2 or 3 states that are allowing full independence of PAs after they've practiced under a physician for a certain amount of hours or amount of years. Then they're allowed to apply for an independent license. So that is the trend that they're headed in. That is in line with the competition that they have on the market when it comes to nurse practitioners who come out and are able to be more independent in many more roles than PAs. But that is going to be something that we'll say for another episode because that is a whole nother conversation on what the educational process and the educational curriculum looks like from an NP or nursing standpoint and how much that differs from a PA curriculum.
Now, have you had PAs directly underneath you before?
I have not. I usually do not supervise physician assistants or nurse practitioners in any of my roles because the majority of my roles have been teaching residents, which there's not too many places that allow physician assistants or nurse practitioners to officially teach. They can come in for adjunct lectures or guest lecturing, but there's not any true compensatory roles where they're getting paid to teach medical students or physician residents.
Okay. Before I jump into a more controversial question, was there anything else that you found that stood out as far as what you found at Rutgers or just what you found in practice?
Nothing that stood out, more things that solidified my understanding of the PA pathway is that they do overlap a lot with the medical students because the clinical rotations that are completed are very similar. They come out during their second half of their second year and their third year. They do rotations through different specialties, just like medical students. They go through gynecology, they go through family practice, pediatrics, surgery, and it's an opportunity for them to get exposure, but also an opportunity to figure out and hone in on what type of specialty they want to potentially pursue. A lot of PAs come out already having an idea of, yeah, I've always wanted to go into dermatology, so that's where I want to focus in on my skill set. Or I've always wanted to work in pediatrics, so I'm going to go pursue more pediatric rotations. The difference in curriculum at Rutgers is that because the PA curriculum is limited to 2.5 to 3 years, they have these required rotations, and those are the ones that they have to do. They only have 2 electives where they can do additional rotations in specialties that they're interested in. Whereas with physicians, because their training is a lot longer, they have more opportunities to do more electives and really hone in on what types of specialties they want to do once they graduate from medical school.
Okay. Okay. Thanks for that. Now I'm going to move into controversy. All right. I'm going to ask this in a way that doesn't make Dr. Long the bearer of controversy. I'm going to ask the negative and then I want to ask the positive because we always like to end on a positive note. Given the underground war that I've identified, the back and forth that exists on the interwebs between physician and physician assistant, can you tell me what would be the biggest complaints from a doctor in looking at the career of a physician assistant? What would be something that if doctors could say it out loud, without any repercussion that they would say about the PA role.
The biggest frustration for many physicians is the ability for physician assistants to be able to jump specialties. Transitioning from one specialty that they're doing for 1 or 2 years, now going into a completely new specialty, whether they have experience or not, and then being able to work in that specialty. Whereas physicians are never really allowed to do that. Once you specialize in family medicine, you can really not go back and become a surgeon. There are some rare cases if you are midway through your training as a family physician and you want to transition over to a surgeon, you can do that. But once you're out after you've graduated residency, it's very difficult. I won't say that it never happens, but it is very difficult to then pivot and find a new residency that is willing to take you on as an older physician now and redo a residency in the new specialty. So that I think is a very big contrast in the different pathways. And that's why it's really important for our audience, anyone that is a pre-med or pre-PA, really consider what are your goals. Is your goal to be an expert in one field forever for the rest of your lives because the physician might be that role for you? Or are you looking for the breadth and opportunities to continue to grow and expand and explore new specialties every couple of years? Because then that might be more of the PA role, because then they are allowed to do that in all the different states.
Now, I'm going to push you one step further because that sounds like a complaint or frustration with the system that has emerged. What are the complaints and the frustrations with physician assistants themselves?
Well, just like any other career out there, there are bad apples and good apples. There are some PAs who have a big ego on them where they feel after they've been in whatever specialty they've been in for 3, 4, 5 years, they feel they've gained enough knowledge to be considered the expert. There are a lot of people on forums out there on Reddit that are PA students or physician assistants already graduated who say that PA school is essentially medical school that is just truncated. So everything that you learn in medical school is just squeezed into 2.5 years instead, trying to indicate that the rigors of medical school, it's even harder in PA school. And I don't know if that is a correct way to compare the two, but that's why I wanted to go through this episode and really lay out that curriculum difference. The other thing is that a lot of physician assistants will feel that because they've been in their role for 5 to 6 years, that they can now talk down to medical students. Because guess what? Medical students are future doctors. And there's this opportunity to say, hey, we're better than you because you're not a doctor yet. And you'll never be as good as me because I've been in my field for a lot longer than you will ever be.
Wow, I didn't think about that, where there's this notion of a PA looking down upon a medical student because they don't have their credentials just yet, but the rigorous coursework that they're going through says otherwise, as to in the long run, the physician might have more expert knowledge in their expertise than a PA may have. But that's very interesting. That's very interesting. I could see that maybe from a legal perspective, like analogizing maybe a paralegal who's been working in the field for a while, who has education and training in the law, talking down to a law student, where at some point in the career, there's going to be a switch over where the paralegal will need to work under the lawyer. They're already working under the lawyer. But in a world where you gave paralegals the ability to practice law, that would change the notion a little bit and could bring out some of the ego and bring out some of the competitiveness that exists between the two. I also think that some people might even say that it's doctors that have the ego. Doctors are playing God. Doctors talk down to people. It's important to point out, like you said, there's good people and bad people in the industry. There's good doctors, good PAs, bad PAs. And it's just what they bring to the table, whether it's an ego or whether it's somebody being truly humble and being truly collaborative. But we always want to end with a positive. What are the things that physicians really appreciate about the PA? What are the things that we respect about the PA, that we look for in a good PA? What are those things?
I think a good PA really complements their physician. They learn how to practice the type of medicine that their physician practices so that whenever the physician is not available, they are still able to follow through with whatever treatment plan they knew the physician would have wanted. For example, if I see a specific type of sinus infection and they know that I don't typically go directly to an antibiotic and that I would want to try conservative management first before I start an antibiotic. A good physician assistant would know that. And instead of just giving a patient an antibiotic on their first visit 2 days after their symptoms started, they would know that their physician does not usually practice that way and follow with giving the patient the appropriate education and say, hey, give it another 5 to 6 days. come back for a reevaluation if you're still having issues. And then at that point, we can give an antibiotic. An even better PA would know what type of antibiotic to give that their physician approves for, but why it is being given and what sort of bacteria it's covering.
So it almost seems like a harmony needs to exist between the two where they can read off of each other. They know the expectations for one another. Obviously, with the physician having more liability and more risk in overseeing the PA, having maybe their own practice or being higher on the depth chart, higher on the hierarchical chart for the system, there needs to be that deference that exists. But the PA, from what I'm hearing, just needs to understand how they can fit into the role that the physician needs, as opposed to being cavalier and trying to do all the things that they shouldn't necessarily be doing out of line from what their physician wants.
Correct. At the end of the day, we're having this conversation, but realistically, on a day to day basis, I don't think that there's that much animosity that we see when I talk to the nurse practitioner or the physician assistant in the different specialty, because I do rely on them to be able to give me the correct information, but also to relay it to their supervising physician if they don't have the answer for me. So I trust their judgment for it. Where you're seeing animosity, it's usually with the keyboard warriors, where they're online, they're on social media, and they have a fake account and they're willing to burn all bridges because it doesn't matter to them, or they're wanting to sow chaos just for chaos sake. That's where we see the majority of this pushback, or the majority of this physician assistant versus physician. But at the end of the day, all of our goals is to make sure that our patients are healthy and happy. The goals are very much in line. And as we move forward, as we figure out the titling situation and how wherever piece fits into this very complex health system, I absolutely see and continue to foresee that both physicians and PAs will be integral into patients' healthcare.
Yeah, and from somebody who's used a physician and somebody who's used a PA, I definitely appreciate what both of them bring to my own health journey and that journey of my family. Overall, this conversation has been a great, informative, educational conversation. I appreciate you bringing the data and seeing the overlap with Rutgers and their education coursework and how they differ and how they overlap. For our listeners, if you are on the track to be a physician, if you are on the track to be a PA, if you are a physician or are a PA, we would love to hear more from you. Please engage, like, comment, let us know what you think. Let us know if you agree or disagree with Lawyer Nik or Dr. Long. That has been a good episode for the Medico-Legal Brief, where medicine meets the law. Dr. Long, as always, we appreciate your insight and input. We have new episodes out every Wednesday at 10 a.m. Central Time. We're also on all the social media, so if you haven't already, click the button below, like, subscribe, follow. We're on YouTube and Spotify. We will see you next week.
Yes, we're doctors. Yes, we're lawyers. No, this podcast is not medical or legal advice. Do not take anything we say as a reason to perform your own heart surgery, represent yourself in court, or diagnose your neighbor's rash. This is for entertainment only. Think of it like hanging out with your smartest, wittiest friends, not a substitute for an actual appointment. If you act on anything we say without talking to your own professional, that's on you. Seriously, don't do that.